Dear all, good evening. I'm Nuha. I'm a member of Executive Committee of BSAP-CH, and I'm a neonatal registrar working in Homerton, London. And thank you everyone for joining us today. We hope that you will find our day is useful and you will enjoy our company. Let us make a start. It is my pleasure today to introduce our speaker, Dr. Umberto Piagio. Dr. Umberto is the parent and a husband who happens to be a consultant pediatrician with a special interest in neonatology and respiratory medicine based at Doncaster and Bassilo Teaching Hospital. He had recently finished his pediatric training in South Yorkshire, and he is keen to support trainees develop their careers using a mixture of evidence-based medicine, philosophy, humor, and comic book wisdom. He will present a 45 to 50 minutes talk about management and leadership. We do have allocated time for questions following the presentation. So please, for the audience, feel free to post your questions in the chat box, and we will try to answer as much as possible. Dr. Piagio, floor is yours. I will remind you 5 minutes before your session, end of your session, just to remind you. Thank you.
Oh, thank you. Well, as I was very generously introduced, my name is Umberto, and I'm a relatively new pediatric consultant, so hopefully I still remember what training was like. And I have the pleasure of talking to you about something that training doesn't really cover that well. In my opinion, it's about leadership and management with that training, and what can we do to fill those training requirements and actually use the skills in leadership to grow as a person as well as a doctor. So I do have some disclaimers. This is a personal topic, and the reason will become obvious as we go along. Leadership skills and leadership techniques are very personal. So this presentation may reflect on my own experiences and my own reflections about everything that I've learned on my pediatric training and during my consultant post as well. And I do have to apologize if when I'm thinking about leaderships and how to lead a team, all I can think is about Avengers and Justice League. So at some point, I will potentially go on a tangent and talk about superheroes, history and philosophy as well. And I think that that really is an important facet of all this, because leadership is not how good a doctor you are, is how good a team member and a team leader you might be. So without further ado, we do have a set of objectives, and we can't really talk about leadership or management or anything that goes along with that without knowing the definition. So I'll talk a little bit about what things are and how they are interpreted in the medical realm. I also will talk about what the RCPCH, the GMC, the King's Fund, what they expect of you as a trainee to develop throughout your career and show once you're a new consultant or a senior trainee for that matter. I also want to touch on what leadership theory looks like, and I'll talk about different styles, skills, things that will be coming in handy about how to develop your own style of leadership. And lastly, it's not because I'm a pediatrician, but you guys will have a little bit of homework, because this talk is the beginning of a leadership journey. And eventually you'll have to take bits of information that I'm going to tell you and apply that on your real life and day-to-day jobs. So first of all, let's talk about some definitions. If you look at the RCPCH curriculum, it talks about leadership and management. Okay, and this is something that over the last 2 or 3 decades has changed dramatically, and the medical field has still got a few miles to catch up with the rest of other enterprises. We still separate those two things. So what is management? Management refers to how to accomplish tasks and goals using organization, planning, staffing, directing. Basically, it's trying to see how you get to that point. But leadership is slightly different. It's described as an art. It's how we motivate a group of people or a team towards achieving a common goal, is having that vision of what we want to do. So if we want to summarize in just bullet point words, management is the how we do things, and leadership is what we do and why we do it. And if you think about pediatric training, we're taught really in the shop floor how to do stuff, how to do the cannula, how to talk to parents in a resource situation, how to deal with a difficult communication or a difficult colleague. But we're not really taught about how to lead that situation, of why we're talking to the parents in that way, or what can we do to improve things as we go along. So hopefully this chat will help on those accords. And let's talk about some examples. And this is probably the first tangent I'm going to have. Whenever I have a leader image in my head, everyone's different. You guys might have a very interesting political figure. I can think of several dozens at this stage. In my head, it's this guy. A leader is someone that will motivate the team to move forward, and I cannot find any more motivating person than Superman. Yes, he is fictional. Yes, he's got his underpants on the outer side. But if you look at him, he is someone that will lead a team, knows that he needs to save the world, and is able to ensure that everyone has a clear vision of what he wants to do at every single stage. He communicates well, he is effective, he is able to hear and listen what other people say and take it on board. On the other side, if I'm looking at specifically Justice League examples, I think of the manager as Batman. He is someone that is very good at doing plans, at strategizing, and making sure that he finds solutions for the problems. But if you think a little bit more closely, he's not someone that communicates very well. He can come as very bossy, and he works in the shadows a little bit. So he's not really that awe-inspiring and glamorous as Superman. In order to work well, the Justice League needs these two guys, but you can see that already they have two different mindsets. One is making sure that everything works in order and is planned and very, very detailed stuff happening, while the other one has a broader picture, broader vision, and makes sure that everyone follows him. So if we have a look at this chart, it's come from the RCPCH Progress. It separates what a manager and a leader does. And you can see from the first bit, a manager instructs whilst a leader inspires. One sets a standard of behavior and the other influences others through their own behavior. And we can go through all that list, but one is more philosophical of an approach and the other one is, for lack of a better word, more managerial, more down to earth. This is from a business textbook. And I just wanted to highlight that even though we're talking about different settings, it's still the same perspective. A leader creates a vision and a strategy. The manager organizes, directs, controls. And to some degree, you can think of a manager as a bad thing, but you really need a manager to make something work as well as a leader. And to some degree, you can think about those two extremes, the leader being pro-innovation, making sure that change happens, a radical change, as it says on the screen, and the manager trying to make things as effective as possible, making sure that everything's as succinct as it can be, and staying with the status quo. But again, this is a fallacy, because innovation and efficacy don't necessarily need to be separated from each other. And I've alluded to this several times now, but I don't think, and to some degree, none of the most recent experts on the field think that leadership and management are exclusive to each other, and innovation and efficacy aren't as well. So just to put some examples, if a consultant comes in and says, I want to save the world, full stop, he's got the vision, he's leading the team, he's saying exactly what he wants you to do, but not how to do it. And you can see this on day-to-day life when a consultant might say, we want this child to go to x-rays, after that we want a gastroenterology review because of this, at the same time we need to insert a long line because we want PN, and we need to speak with pharmacy, and you've got a list of about 20 something things that you need to do within the next 2 hours, because after that everything closes. That's not management. That consultant has lost his sight of how to manage that situation and manage the team's expectations. On the other side, if you've got a lot of management, several guidelines from the region, the local hospital, the local tertiary center, all saying different things, and the consultant is not able to say, we'll pick this one over the other one. Or on the same side, if you've got so many cooks in a resus situation that no one's taking the ownership of that resus, you'll see it very often. Someone eventually down the line, 20 minutes down in resus, says, who's actually leading? Because that is an important role. Everyone will pitch in with ideas, but someone needs to filter all those ideas and provide the vision and the direction of where you're going. So in summary, I could probably do a whole chat about who my favorite superhero is, but I'll cut short. It's this guy. You've probably never heard about him. His name is Nightwing, and he's best known for being the first Robin. So he trained under Batman. He is a great detective. He's a very skilled athlete. He's someone that doesn't have superpowers, but has developed his skills so much that he's able to fight alongside people like Superboy, Superman, and the rest. But he also grew up looking up to Superman. And he's a product of those two mentors. In order for you to train, develop, grow in pediatrics, you have to pick your mentors and people you look up to and pick the best things of them. Nightwing picked the best skills that he could potentially get from this manager, Batman, and got the leadership styles from Superman, and made his own style so good that in one story arc, he was basically the unanimous choice to lead the superhero teams of the world. And several times in DC Comics, they've tried to kill this character, and he's so loved by everyone that basically it backfires, and every time they try to do that, they change their minds. So if you have the chance to read about him, he is awesome. And he applies to pediatrics in such a good manner that I couldn't fail to mention him. He has trained to be like this. Leaders are not born, they're trained. They develop their skills as time goes along, and training in pediatrics will do just that for you guys. The expectations come in different forms. The GMC has a very generalized view about leadership, and you can read this document if you have the time and want to learn a little bit more about that. But this quote that I've put here is summarizing it all. A doctor needs to provide leadership to their colleagues and support the vision of the organization. You can put this on on the chat group if you want, or you could comment that at the end. But I have a question for the people out there. How many of you know the vision and strategic direction of the places you work with? Do you know the motto of the hospital that you have? How about the NHS? If you don't know where the direction of your organization is going, how are you trying to change that or to lead the situation within that environment? It makes you food for thought, really. And it's something that I've recently realized as a consultant. If I didn't know where my clinical director or my medical director, for that matter, wanted to move the department, I would probably be rowing in a different direction to them. So we need to work as a team. And in order to work as a team, we need to be respectful. We need to be able to improve everyone's performance and make sure that all of us are working for the patient's benefits. It's not just a team that you work with. It's not just a medical or nursing staff. It's also the person on the front desk that's going to make the appointments. She might notice that the very old pediatric patients that we have, the teenagers, are unable to make it at 9 in the morning. So she books them at the latest appointment possible so they are able to go to school. That is leadership. And we don't recognize that very often. But it's making sure that everyone works with the same goal and the same vision in mind. For those who don't know, the King's Fund is a well of knowledge. I would encourage everyone to at least browse through their podcast sections. It's on Google and Apple Play. They have very interesting podcasts out there, and I'll point towards a few of them at the end of the presentation. They have developed this leadership and leadership development in healthcare information leaflet. More than information leaflet, is a guideline. It's about 79 pages long, but it goes into how we should be developing leaders in medicine in general. And they have a faculty of medical leadership and management that you can actually do an UP with and work with the BMJ as well and gain some experience. Long story short, other than the quote in here, they basically say that thinking about an NHS system without leadership, it's just unthinkable. It will be catastrophic and could be catastrophic if little areas of the NHS happen to be leaderless. Now, a little bit more towards home, the RCP expectations are divided on two general areas. One is the leadership competency framework that's arranged with the rest of the Royal Colleges. And the other one goes specifically to the RCPCH progress curriculum. The first one, the Royal Colleges, look at this chart, and it's to some degree self-explanatory, but it goes through level 1 trainees up to level 3, in which, for example, in level 1, when you're demonstrating personal qualities, you are supposed to develop your own self-awareness, your integrity at work. You're going to have some development of your communication skills. Whereas on level 3, they highlight all this because in theory you've already sort of ticked the boxes. You're not only demonstrating, but you're polishing your skills on communicating in a difficult situation, or making sure that you're able to lead a multidisciplinary team. Different areas of the hospital might be talking in a different language. So for example, if you talk about neonatal acronyms to an endocrinologist, they might not be even speaking the same language. Able to translate that is an ideal leadership skill. And the second thing that RCPCH talks about is the domains, and you probably are more familiar with this than the previous one. And I just want to highlight that the journey from a level 1 trainee to a level 3 is quite steep. Level 1, it only asks you to recognize why leadership and team working is important. You could do this with this talk, and you could probably just tick that box already. But at level 2, you're supposed to demonstrate that you have your own leadership qualities and that you're participating on those multidisciplinary teams. Within 2 years, you're supposed to lead them. So you can see how this can be very vague, but hopefully throughout the training, what you'll learn is that this stepwise approach is actually quite quickly managed by some. And you need to take the opportunities to learn from your seniors, your colleagues, your juniors as well. I've learned so much from SHOs when I was a registrar regarding leadership skills. That's amazing. All you have to do is have your eyes open. And for those of you who are senior enough, you will have a level 3 curriculum. And I just wanted to highlight that some of the areas that are in one color, for example, the resuscitate, stabilize, and treats are very managerial. It tells you exactly how things should be running. Your APLS or NLS resuscitation skills, they're quite standard. Your stabilization skills, everything needs to be as efficient as you can. Whilst others are a little bit more vague and philosophical and a general approach. So, for example, coordinates and leads the care of the children, liaises with primary care. And I really enjoy this last one, supports and communicates effectively with families. Because you have to remember that families are also part of the pediatric team. They're part of the integrated care system that pediatricians are involved. So in order to be a good team leader, you also have to be involving them. And this is Nightwing once again. Whenever people talk about leadership and team working and getting more responsibilities and stuff like that, they all come back to a very famous term, that's the imposter syndrome. I'm assuming that people are aware, but for those who are not, it's that sensation that you're basically wearing a mask and you're not really the person that should be, let's say, leading the situation or doing the difficult intubation. You think that you're just posing as someone that is supposed to be doing that. But actually, what Nightwing once said is that if he had to choose a superpower, top of the list would be flying. Anyone's could be flying. But he's learned that he loves falling too. And what I read into that is that he enjoys learning through the process. He doesn't see falling or failing as a failure. It's almost making sure that the groundwork is done appropriately so he keeps on building and improving his skills and getting better for the next time. And that mentality is the one that's going to change you from someone that is going to be stunned by a difficult situation towards someone that will take action and say, okay, I failed on this the last time, I did this, what I'm going to do is try this different approach. Okay, so let's talk about some theories, but first of all, I just want to take let's say a minute in your own heads, or if you want to put it on the chat as well, about thinking about the best situations and the worst situations that you've encountered regarding leadership. And think about why they might feel the best and the worst. I'll just give you a minute or so, just for the sake of time. And after that, I'll tell you my story about my experience on this. Okay, guys, that's a minute. So hopefully you've all thought about this and it's in your heads. It's good to start thinking about different examples. And actually, for those of you senior enough to start thinking about your consultant applications, this is probably one of the questions you might actually get uh, about leadership examples and stuff like that. So my personal example is a mixture of both. It was a situation I faced in which I saw the best type of leadership and the worst type of leadership in one go. I got a call from my wife. I was on call in a DGH, and she basically said that I needed to go to the hospital because she was going on premature labor. So obviously, I needed to abandon ship, run towards the hospital, look after my wife. But I did the conscientious thing. I literally run towards where my consultant was doing the ward round. I told him the situation, said I need to leave. I'm on call, but I need to tell you, I just cannot stay because of this reason. I stated my wife is going on premature labor. I need to go. As I was leaving, because I didn't wait for a reply, as you can imagine, this particular consultant said, "You can't go. You have to stay. You have to do your own call." He wasn't listening to me. He was taking ownership of the situation, but he wasn't demonstrating a open communication. He was being hostile, not listening to my feelings as well as what I was saying. And I was working at the time with a registrar. He probably wasn't more than an ST5, ST6 at the time. And he basically told me that I needed to go, that if no one found any other SHO, because I was an SHO at the time, to cover, he would stay, he would take ownership of that situation, he would do whatever it took for me to be able to go. He was honest, he listened, he made sure that the team was okay, he made sure that the patients were okay by staying late. And after that, I found out that he actually told the consultant off separately. So he also had very good communication skills that my consultant didn't have. So that single moment really explained how different leaderships and how different leaders might approach a situation. And one showed a clear example of good leadership, and the other one of the worst possible leadership. So, what are the rules of the game then? What are we expecting of our leaders? First of all, we are expecting them to know their area of influence. And this is where the theory starts. So hopefully I won't bore you too much. This is a chart that looks at your area of influences. And this is very simple. It could be extrapolated down to 7 or 15 different circles, depending on the complexities of the system. But it boils down to these three: your influence in yourself, on your team, and your system. Why are they areas of influence and why do they differ to each other? Well, if you want to influence yourself, all you have to do is make a decision. You don't really need, let's say, negotiation skills unless you have multiple personalities. You don't need to make a very complex plan or push people around in order to get your goal done. You only have to do it for yourself. With the team, you also need to start negotiating and making sure that they understand your point of view. You need to see how your vision applies to someone else's vision or someone else's plan. And then if this team makes something good, a nice, let's say, algorithm or guideline, then you must think, could this be applied to the system? Could this be applied to, let's say, the whole region in pediatrics or national guidelines? Is this way of measuring blood sugar efficient in a newborn baby, or should we be using this other technique that this hospital is doing. So at the end of the day, we can start either way, depending on how strong you are in the system. You might start with a system, but usually the rest of the humankind, like myself, will start with myself. So as Batman said, if you want to make the world a better place, take a look at yourself and make that change. We need to start making change on ourselves so that we can start looking outwards. Then there's a guy called Simon Sinek, who is, I suppose I could describe him as a leadership guru. He does talks for Apple, for Microsoft, and he's developed this golden rings chart, in which he mentions that usually we have a followership mentality. We know what to do, how to do it, and at the end of the day, we know why. But that's not very inspiring, let's put it that way. For example, if I said to you, the what, I'm a pediatrician. How, I worked for 8 years and trained in the UK to become MRC-PCH compliant, and I CCT'd. Why? I like kids. I like working with them. So that process doesn't really tell me that I'm a leader. It's just I am following a structured pathway. But if I do the other way around, the why, I think that by looking after and caring for children, we are going to improve the world's health in significant ways. We're going to make functional adults, happy adults that will thrive and create a better environment for everyone. How is that going to happen? Well, I work very, very hard for the last 8 years to make sure that I am as best a physician as I can manage. And I've developed special interests to help me develop that goal. So what am I? I'm a pediatrician. Do you see the difference of approach? One is telling you why I'm doing this from the start. And what I'm selling is becoming a pediatrician. You can't really do that from the other way around. And RCPCH will talk about this GROW model to help you assess where you see yourself now, in a few months' time, in a few years' time. And with medicine in general, we love acronyms. This is the GROW stands for goal, reality, options, and will. So what do you want to achieve? What is your current situation and what's your environment around that situation? What are your options, and have you thought about different possibilities or obstacles that are in your way? And do you actually have the will to finish that project? Because let's face it, we've all seen that person that is really encouraged to do an audit, then halfway through the data collection, they just give up because it's boring. You have to identify specific tasks that will help you go and motivate yourself and others to accomplish those goals. So moving on to the theory of leadership, you can divide them on two very big areas. One is the boss, or the dictatorial, autocratic leader, and the other one is the definition of leader, democratic or inclusive one. And you can see by the pictures how they differ. A dictatorial leader is someone that thinks everyone hates their job. And if they hate their job, we need to make sure that they actually do it. Because if you give them an inch, they will start looking at their mobile phones and play Candy Crush. If you give them a day off, they'll ask for 2 days off the next time. That's the type of boss that you really don't want to work with sometimes. And a leader is one that motivates and makes sure that everyone's satisfied with their jobs. But as we'll see later, it's not just black or white, it's actually a whole palette of continuous movement. From an authoritarian to a democratic leader, you will have a mixture of things. And you have to realize that being an authoritarian leader doesn't really mean it's a bad thing. There are certain situations in which you do have to tell your juniors or other team members, you have to do this. And you have to observe them doing them. Not only because it might be that you're doing a DOPS or a mini kegs, but because you have to ensure of your patient safety. When we are trying to empower trainees and colleagues and nurses and other people on our team, we also have to be aware that we're just delegating the freedom to make that decision, but not the accountability. Whoever is empowering someone still has that responsibility with them. And as a consultant, that comes in quite important. You don't know what's happening at 3 a.m. in the morning if you're not called. On the flip side, if you are empowered by your consultant or registrar to make some decisions, it would be a good idea, if you're not completely sure, 100% sure, which hopefully none of you are, to double check and make sure that you build that confidence level to a point that you might not need to do that next time. So there are different styles, and depending on which author you pick, you can find these 6 definitions, or you can find completely different ones. So if you're interested on leadership styles, feel free to have a browse through the internet. You'll find different ways to categorize them. But I found these ones useful because you will have the very coercive leadership style to begin with, but you end up with a very approaching, teaching the next generation kind of leader at the end of it. So let's talk to each one of them. So the coercive leadership, and for those who haven't recognized this guy, he is Niccolo Machiavelli. He is very famous for his book, The Prince, in which he talks about how a new ruler should be not mean, but very manipulative and Machiavellian, to describe it. And he does have a point. If you are a new leader in a very tumultuous time, you do have to make sure that you are self-controlled, that you show initiative, and you demand that there's a compliance with what you're saying. So this is a do as I say approach. But in medicine, this is quite useful in a research situation. You know that it's a crisis. You know that things need to be done as soon as possible. You need to stand up and assert your leadership status. So you stand up in a small stool, say, I'm the leader, you do this, you do that, tell me what the gas is. Someone speak with the parents, I need a scribe for this situation. So you're showing an initiative, you're showing control of the situation. So it's not bad. And actually, as a side note, Niccolo Machiavelli also wrote a book called Discourses. If anyone's interested in philosophy, it will change your point of view of anything that's Machiavellian. Then you've got the authoritative leader. And this is a little bit more towards the, let's talk to the team a little bit more, but you're not really giving them too many options. You are giving them the blue pill or the red pill, but you're moving them towards a certain goal. You show that you're able to communicate with the team, that you're empathic with them, but also that you're confident enough to make to limit the decision making. So, for example, if you are in a situation that you have given this wheezy child so much salbutamol, so much IV medication, that you're actually thinking, could this be something else and not asthma? Could this be cardiac in origin? Could this be a foreign body? You offer those two questions. Do we think we need to do an echo first, or do we have the capacity to do an echo? Or shall we do an X-ray and see whether or not there's any features of a foreign body? Maybe a CT scan would be better. So of those two options, you give that to the team. An affiliate is someone that is really good at people interaction. It's someone that builds the harmony and the bonds, someone that's very diplomatic and will be able to speak with different team members who might be in conflict. And they are very good in managing, for example, I think the newest term is a professional parent, not because they're doctors themselves, but because they have taught themselves a lot of medicine, and sometimes they can be quite difficult to manage. Expert parents is another term, and there's a lot of research out there. So there was one in 2011 BMJ article, if anyone is interested on that. But having a diplomatic approach is quite useful in those situations. Then you've got the democratic team leader, in which he very openly asks the question to the team, what do you think? He tries to forge a consensus and gets a new direction. So for example, if you want to change your guideline, you have read about the new Kaiser Permanente calculator for neonatal sepsis, and you've noticed that your neonatal guideline has not been changed since 1998. You're trying to forge a change or a change in direction by speaking with the public. Do you think this we need to include this, or shall we just go with an updated version of the NICE guidelines? So hopefully by obtaining feedback, you will get a consensus and a new direction. A pace setting is slightly different. It's not a coercive leadership style, but it's not a completely democratic one. You have a situation in which you need quick results. And this is a leader by example, in which you're showing the rest of the team what needs to be done and how. So the example I came up with was, if you are in a situation that you have a very difficult night shift and you need to go through a lot of patients, you might be comfortable saying, okay, you see this patient, I'll see that patient. If you're happy with that patient, go for the next one. I'll start looking at the other one. And you pace set by example. Another one might be if a neonatal consultant wants you to do the Badger summary for triplets that are about to be transferred to from a DGH to a tertiary center. And she wants this to be as detailed as possible because these children are unwell. She does the first one and tells you, you have to do the other one. We'll find out someone for the third one, and we all work as a team. But she sits down and sets the example. So you're motivating the team by leading. And lastly, we've got this little fella that is teaching the next generation of Jedi or pediatrics trainees, if you want to call them that. They are under your care or working with you to develop their skills. And you might be more experienced in cannulation, you might be more experienced in communication skills, and you might want to just say, why don't you try this? It worked for me. And at the end, we're helping to improve the performance of everyone around us and raising the bar so that everyone's, the patient's care is improving. So let's do a bit of window shopping, because I think the next few slides are important more for self-awareness than anything else. But if we are self-aware, then we can build up on our leadership styles. So this is a very broad window in which it basically shows if you're conscious about how well you're leading and how competent you are as well. And you can see that there are 4 boxes, mixes those 2 criteria. And you might have someone that is very conscious that they are as skilled as they could possibly get. They're neonatal grid trainees that have done pediatric transport medicine. They've done an UPN simulation. They have written the guideline on management of 22-weekers in extreme prematurity, and they have intubated 15 22-week gestation babies in the last month. They're more than happy to lead the resource on that situation. But then you might have someone that doesn't have that skill set, but has managed competently a 22-weeker in the past. And they might still feel uncomfortable, but the rest of the team sees them as the most experienced person there and the most capable person there. So you can see that in one side, there's a clear definition. I am the leader, I will do this. On the other one, everyone looks at you as the leader, but you don't see yourself as well. And that the dichotomy can lead to some issues. You might not declare yourself as a leader. People might assume that you're a leader, and down the line, the consultant comes in and says, who's leading the situation? Everyone looks at you and you think, well, I was just bagging. I was not taking the decisions. We've got another set of leadership styles in which you're conscious that you are basically not the leader. You are an ST8 in gastroenterology that for some reason that ended up doing a locum shift in a DGH, and you weren't expecting to have a 22-week unexpectedly delivering. You haven't even read or were aware of the new BAPN guidelines. You haven't intubated a pediatric person in almost 6 years. You know that you shouldn't be leading that. So you are conscious that you're incompetent. Not that you are incompetent on anything else, but you're incompetent in that situation. And then you talk with the team about your limitations. I'm happy bagging, I'm happy doing this, but please someone call the consultant as soon as possible so they take the leadership out of me. That type of thing. And the most dangerous one is the unconscious incompetence, in which you probably are not self-aware at all. And you are faced with a 22-weeker and say, yeah, I could probably tube that. I've done it in a simulation. I should be able to do that. And you're not self-aware enough to call for help. You're not self-aware enough to think about the extra repercussions of stuff. So this is a readiness to lead window. And this one is more of a self-awareness, making sure that you know yourself and the team gets to know you as well. This is called a Yohari window. And for those of you who want to go a little bit more into the leadership program, you'll be very familiar. And basically, it's a repercussion of the same. You know yourself, the team knows yourself, everyone is happy with the situation, and it's an open dialogue and discussion. If you are competent, but you don't tell anyone, or people do not know your skills, then you're not going to be able to use them. It's all hidden. If you are thinking that you're not competent, but everyone else sees you as competent, you are blind to the situation. And again, if you don't know yourself, you don't know the others, you're in no place to really lead anything. And this is a chart from Hertzberg et al., in which basically we separate your positive satisfaction events with your dissatisfaction events. And for those of you with good eyesight, recognition of people's abilities is quite high up here on improving the morale. But having a boss that is able to cannulate is quite down on the hygienic factors. It can cause grievance because they tend to take the procedures away from you. You don't want someone that's going to micromanage. You want someone that will be able to improve your skills and teach you how to do stuff in the future. So how to be a leader? What type of leader will you be? We've seen basically the last 6 styles, but I want to talk to you about this guy. It's Marcus Aurelius, and yes, this is the guy from the Gladiator movie. He was also described as a poet emperor and a philosopher. He is the head of the Stoic philosophy group, and he developed what nowadays we would call an emotional intelligence, being self-aware, aware of the situation, making sure that you're able to cope with different possibilities. He's famous for a quote of his saying, I'm never let down in my life, because every morning I wake up and I say, people will let you down, and they will not do as you say, and something bad will happen. If that happens, my mentality is I'm already prepared for it. And if it doesn't happen, it's a good day. I'm not saying that that's the way you guys should approach life, but I have heard something similar on a recent leadership podcast in which a consultant ended up the handover saying, okay, I will open a bottle of champagne today. No one's died, everyone's still breathing. It's a happy day. And you can see how setting your emotional bar quite low can be beneficial for someone like him. But bottom line, you need to be self-aware. You need to be aware of your skill sets and the environment that you're in. For those of you who like doing questionnaires online, you can do one of these. It's not very evidence-based medicine, but it is probably one of the only tools that we've got out there. It's called the Myers-Briggs personality chart. And it separates some traits, well, 4 traits by doing multiple questions. And it will tell you if you are a counselor, if you are an idealist, an executive. And it boils down the qualities and characteristics of each one of these groups. So it might give you a bit of an insight about who you are and what you should be able to do or perform. What are your strengths? What are your weaknesses? Again, if you're thinking about a consultant interview or an interview in general, these are good things to do. But whatever you do, don't pick the character and then think about what traits you want to take on board. Not everyone is going to be Harry Potter. Not everyone's going to be Luke Skywalker. There are good things about being Palatine and being Dumbledore. You will be able to see your own strengths, not those strengths that you want to have. Now, Jung is slightly more evidence-based. He did work a lot on this process, and he's actually a psychologist. But again, this is a breakdown of your personality traits, and it gives you a combination of archetypes more than a single personality group. It will give you a group, sorry, a major archetype and a sub-archetype to play with, and again, gives you strengths and weaknesses of them. So my homework for you guys is that we need to start reflecting about our own practice. And the best way to do that is by getting feedback. Obviously, you will have your MSFs, but also as feedback from people you work with. How do they look up to you or down to you? And why is that? Why are things coming your way in such a manner? Try and make the opportunities open for you and look at the departmental and operational meetings. Most of my training, I shied away from them. I have to be very honest, but at the later stages, I have found out that those are very, very good skills to observe and learn from. So if you have the opportunity to do them, please do. Some of you might have already done shadowing. I did that myself for a little bit of time outside the training program. But shadowing within the training program is also quite important, because we will have the opportunity, for example, to see what a grid trainee does on a day-to-day basis, or what a consultant does on a base-to-base basis, and learn from what they do, either the good things or the bad things, and make your own style. There are some mentoring programs out there, both from Health Education England as well as the RCPCH, some local ones as well. But you might be the mentee, or you might be the mentor. As long as we're trying to build a progression of the training and the supporting of the staff, of our colleagues, we will be going towards a leadership journey. And attending multidisciplinary team meetings, teaching sessions, they will all tell you how different people take on board the leadership roles and responsibilities, and again, gives you an opportunity to learn from observing them. Taking on board projects that you care about will also give you a very good insight of everything that you might need in the future as a leader or a manager. And as I said before, there are some leadership programs out there that you can apply to and learn a lot more of the theoretical bits as well as the practical issues of leadership and management. So I hope I haven't bored you too much. I don't see any questions on the chat group other than asking me if I'm an ENFJ. I'm not. I will leave people to think about that later on. Let's see. Difference between department.
Yes.
So the difference between a departmental and operational meeting. So a department, let's say that you have a pediatric meeting. It would be difficult for a trainee to be on board on the consultant meeting because we do discuss trainees from time to time and different aspects of their training. But you could go for a clinical governance meeting and learn about root cause analyses or audits, and so how they're going to change the way we work in the system. Whilst the operational meetings are more what's happening in your hospital. So for example, my wife has had the tremendous opportunity of being the, not leader, but the trainee representative for her local hospital to go green. And she is attending board level meetings to try and support changes from salbutamol inhalers to from Ventolin inhalers to salmeterol that has a better, less CO2 impact. But people are able to join those meetings without being part of the meetings and looking at what the board members do, the non-executives, the chief executives, the medical directors, the departmental heads. It will give you a lot more information. How to reflect on leadership on your portfolio. It's how you would phrase your experiences, because everything that you do can be put for a leadership option. I would strongly encourage non-clinical activities as well, because we are human beings and leadership is not just being able to lead the resuscitation. I'll talk about some examples in the next few slides. Am I missing any other question? Probably not at the moment. So I'll just move on. And this is probably what the last question was all about, how to put things on your e-portfolio. I've divided things into 4 different categories. The clinical scenario is a classical one. I usually get a leader CBD because the trainee led a resuscitation scenario or a ward round. But it doesn't have to be all clinical. You don't need to be a leader only on crisis or medical crisis. You can also have a leader CBD or a reflective practice of how you led a situation by some governance scenarios. So I remember I reflected on my leadership skills when I was doing research. And I also reflected on my leadership skills when I took the lead on doing teaching sessions. Being able to decide, I want to do this audit. It's not that someone gave me the audit. I wanted to do it because of this decision and this is how I changed something. It's also telling about your leadership journey. So I would probably do an audit entry saying, you've done this, but also do a reflective practice or entry related to that scenario. Non-clinical things are also involving how you're looking after your team's well-being. Thankfully, I don't need to do Kaizen anymore, but I still need to do some reflective practice of how I'm trying to improve things in my workforce. And for those people who have joined me as when I've become a consultant, I've made a point that at least once a week, I buy people either a coffee or pizza. We sit down, we talk about things and how things are going. On the weekends, I bring something for breakfast, croissants or something, um, as a sign of support for my trainees, making sure that they feel appreciated. It's not because I'm a good doctor, it's not because I'm a consultant, it's not because I'm a pediatrician, it's because I want to look after my team. So as part of that, I might reflect that on my next set of 360 source feedback. And the last one is examples of change. And this is a little bit more esoterical because leading change is a progress, and usually you will have to link several scenarios or several sessions to make that obvious. At the end of the journey, you have to put an entry about leadership of how, by doing these changes in your life, you may realize this is something we can do. You used your communication skills to speak with the rest of your team, looking into your area of influence, saying, actually, we are junior doctors who move every 6 months, and we get the same induction on different hospitals. I don't think that we need that. I've spoken to different hospitals. Yes, they are aware they're using the same system, and what they've agreed to in these two hospitals that I've just rotated is to do one single induction meeting for all pediatric trainees for a year. And after that, we can review. After that year, it worked so good that you've expanded now to the whole region. After 3 years, you have realized that this has worked so well that all you have to do is just updates every so often instead of the whole 3 hours worth of listening to the same video over and over again every 6 months. Obviously, this is something that I wish happens, but you can see that it's a little bit more esoterical, a little bit more out there. It's a vision more than something that you've actually done. Okay. So my top tips, just to finish this talk, would be that you need to lead with different styles and with style. You have to be a little bit more egocentric sometimes as a leader. But you have to be aware that different situations will need different leadership styles. Okay. You need to do reflections. You need to be self-aware of who you are and what your role is on different situations, and learn from past experiences and reflect, okay, did I do this right? Could I have done this better? Or actually, I thought I didn't expect this to go this well. Why was that? You have to be empathetic and supportive of your team. You have to make sure that they are listened to and that you are talking with them and not talking to them. I think I've actually skipped one. There's an NHS non-executive called Lord Victor Adamwale. I hope I'm pronouncing that right. That gave this term fast patience, which I particularly love. It's being patient enough to ask the right questions in order to make a positive change for your patient, but being impatient enough to expect answers soon and make the appropriate changes as soon as you have the answers that you require. You also need to be childlike. And I don't expect you guys to love comic books or science fiction like I do, but you have to have that open-mindedness of, I want to know why, I want to know how, I want to know more about myself and how I can improve things. And that will just help you in general in life, because that curiosity will motivate you and it will be infectious. You will see that the rest of the team wants to do the things that you are doing as well. And don't forget to look for opportunities. They're out there. Yeah. Sometimes we run such busy lives in our inpatient a hospital setting, that we forget that we're there to train and that we are meant to be training others as well. So look for the opportunities and make sure that those opportunities that you take on board are something that matters to you, not that someone else just imposed on you for whatever reason or their own agendas. In order for something to work for you, it has to matter to you. So in summary, leadership and management should not be apart. They are one and the same. In order to be a leader, you need to be self-aware. You need to be able to lead yourself. You need to have the confidence to lead yourself in order to lead others. You don't need to be the clinical director of an NHS trust. You don't need to be any consultant or registrar. You can just be the person that registers the child into the outpatient and thinks, actually, could I book him later on or earlier? It's the person that thinks about, do we need to see all this jaundice patients or every single day, or is there a better option? And if you listen to Don Berwick, who is an absolute genius, and I would encourage every one of you to listen to him, he basically says that the best thing that the NHS has for itself is the existence of junior doctors. Junior doctors see everything. They are there in the nitty-gritty. They are on the ground floor. They see how things happen, and they have all the ideas for positive change. So change is not going to happen from an ivory tower that we are the next Jeremy Hunt and tell you this is exactly what needs to happen. The junior doctor's voice is even more important than whoever is on the top of that tower. And there are plenty of opportunities to develop these skills. It's just a matter of keeping your eyes open for them. If you're as nerdy as me, you'll probably look through a couple of these further readings. And as you've seen at the bottom end, I've just put almost anything that Dr. Don Berwick has ever written is worth having a look. And if you are not a reader, but you are commuting to work and you like podcasts, I've got some links to some of the podcasts that I found particularly important, both for leadership as well as general quality improvement, management style thinking within the medical professional. If you're interested on out-of-program experiences or teaching about leadership, there are some links to some toolkits and programs as well. And if you want to know whether you're a Slytherin or a Gryffindor in the Myers-Briggs, I've got 2 links as well for you to play with. So I hope that was helpful. Thank you very much for taking your time out of working hours so that you basically listened to my voice for an hour. Hopefully it was useful for everyone. Thanks.
Oh, definitely it was joyful to have you. Thank you very much, Dr. Umberto. This from me and from the audience on the chat box. They are all thank you for such informative and concise talk. We have really enjoyed. And I would like, by the name of BSAP-CH, to thank you very much for joining us today. Your valuable contribution is much appreciated. Thank you.
No problem. I will be sharing the links to the chats so people are putting that on that. I will send you the presentation later on if that's okay.
Okay, thank you. Appreciate it.
No problem.
Thank you, everyone.
Thank you.
Thank you.